Hello everybody, this is FMGE Recall Question July 2023. I'll be taking one by one all the questions which were asked in this FMGE. Meanwhile, you also can suggest if any other question were asked. Alright, so let's see the question one by one. Just say quick hello so that I come to know that everything is alright. Audio, video, my voice is clear to you. So good evening everybody. Yes, welcome everybody. So there were many questions which were asked this time in FMGE, and most of the questions were very much clinical questions where application aspect of the biochemistry was being asked. And let's see the question one by one. So the first question is, right, the first question which was asked was 5-fluorouracil. This is converted to its active form. What is the active form of 5-fluorouracil? It is 5-fluorodeoxy-UMP. From active form after administration of a drug that further leads to destruction of the cell. Which of the following type of inhibition best describes the mechanism of action of 5-fluorouracil? Right, so you must know what this 5-fluorouracil is actually doing to inhibit the DNA synthesis. It is used as an anti-malignant drug. And you must know 5-fluorouracil it is anti-cancer agent, and mainly it is used for colorectal cancer. How it is effective as an anti-neoplastic agent is the question. So 5-fluorouracil is first of all converted to 5-fluorodeoxy-UMP, right? And then we must see that this deoxy-UMP is the important precursor because it makes you TMP. This enzyme is thymidylate synthase. This enzyme is thymidylate synthase, and this needs N5N10 methylene tetrahydrofolic acid for methyl donor. So methyl is being donated to deoxy-UMP, and that UMP is converted to TMP, and this is in turn converted to dihydrofolic acid. Now 5-fluorouracil is going to inhibit this enzyme. How? The answer is, this 5-fluorouracil, after getting converted to 5-fluorodeoxy-UMP, this 5-fluorodeoxy-UMP thymidylate synthase and N5N10 methylene tetrahydrofolic acid is going to make a irreversible complex. This is going to make you irreversible complex which is going to inhibit the action of enzyme. Generally, at the place of 5-fluorodeoxy-UMP, you need to have deoxy-UMP, like I have shown you in this reaction. Then only the reaction will be taking place and TMP will be formed and the DNA will be formed, because TMP is an important component of DNA. So what happens in presence of 5-fluorouracil? 5-fluorodeoxy-UMP is going to make the irreversible complex with the enzyme and going to inactivate the enzyme. This is the exact mechanism how this 5-fluorouracil is going to work as an anti-neoplastic agent. Now if we see the question which were asked, they were asking which of the following type of inhibition is best describing the mechanism of action of 5-fluorouracil. So it is not mechanism based inactivation, because action of thymidylate synthase is not utilized to convert the 5-fluorouracil to 5-fluorodeoxy-UMP. It is not non-competitive, it is not allosteric inhibition. Right? It is going to be formation of irreversible complex which is going to inactivate the enzyme. And at times they say that this 5-fluorouracil, 5-fluorodeoxy-UMP, which is produced from this, is going to compete with this deoxy-UMP. 5-fluorodeoxy-UMP is going to compete with this deoxy-UMP, and so the proper TMP will not be formed and the DNA will not be formed and cell will be dying. So in a competitive manner also it acts. So there are two mechanisms. Number one, it is like sort of spoiling many of the enzymes by making irreversible complex with them, and the remnant enzymes are being competed by this 5-fluorodeoxy-uracil monophosphate, because deoxy-UMP and 5-fluorodeoxy-UMP, they resemble structurally, so it's a competitive inhibitor. So in this question, the best answer is going to be a competitive inhibition. All right. Yes, very good. So if there is any doubt, you can ask me. Otherwise, next I will proceed further, and next question I will be taking. This is the question which is talking about the poor wound healing, and this is due to deficiency of zinc. Zinc is important for wound healing. Zinc deficiency is related with diarrhea in the child, growth retardation in the child, and poor wound healing. So zinc deficiency is related with all these problems. So answer for this question is going to be this. Copper deficiency, the most important thing you must know, in deficiency of copper, there will be collagen malformation. Collagen will not be formed adequately. So the bone, the blood vessels will not be produced properly. Even copper deficiency anemia is seen, because copper is important for iron metabolism, and in copper deficiency, you tend to develop iron deficiency anemia. And iron, of course, it is important for making of heme, which is important component of hemoglobin. So iron deficiency, you find iron deficiency anemia, right? And when we are talking about selenium, this deficiency is rare, but selenium deficiency is related with heart related issues. You must know it is cardiomyopathy, selenium deficiency, cardiomyopathy, right? It's called Cation syndrome, K-E-S-H-N, Cation syndrome. So the answer for poor wound healing is going to be the zinc deficiency. All right, zinc deficiency. So if you have any doubt, you can ask me in this question. And if not, I'll be proceeding further. And the next question was talking to you about farmer spraying odorless chemical in the field, which is inhibitor of complex 3 of electron transport chain. So you know the complex 3 inhibitors are? Complex 3 inhibitors, what are complex 3 inhibitors are? When you're talking about electron transport chain, you have got coenzyme Q, and that coenzyme Q is surrounded by 3 enzyme complexes, complex 1, complex 2 and complex 3. Then you have got cytochrome C, then you have complex 4, then oxygen molecule, which is converted to water. So these are various complexes, and on this the electron is flowing towards oxygen molecule, right, like this. So when we are talking about blockers, the block may be here at complex 1. This is going to be pyridine, amobarbitol and rotenol. These are blockers within the complex 1. This is going to be carboxyl and TTFA, blocking the complex 2. At the level of complex 2, the electron transmission is being blocked. Within complex 3, you have British anti-lewisite, and antimycin E. And within complex 4, you have cyanide, carbon monoxide, hydrogen sulfide, and sodium azide. right? So these are the various blockers which are blocking the electron transmission on electron transport chain. So if you see this question, complex 3, directly they are asking that spray is blocking the complex 3. So the answer in this question will be British anti-levisite and antimycin A. Both are the correct answer here, right? So I just want some correct recall from your end for this question. So I have told you the various blockers at different level of electron transport chain, so you can relate with that. And there is one more question which where they were asking about rotenone. I will be showing you that question. All right. So I just hope this was a correct recall. Coming to question number 4. A neonate, few days after birth, suddenly becoming lethargic and starts refusing the breastfeeding. And the neonate is going to vomit the forced breastfeeding. Mother is also stating that baby is having diarrhea on 3rd day, and clinical examination is revealing that child is presenting with oil drop cataract. There's a lot of catch in the question. The baby is very young, 3-4 days old baby coming, and there is problem with the breastfeeding. So milk related issues are there with the baby. Diarrhea is also there with the baby, right? So what is the most likely diagnosis? So the oil drop cataract is a strong hint here, and that is seen in all types of galactosemia, whether it is classical galactosemia or even it is benign galactosemia. Even in case of benign galactosemia, you find this oil drop cataract. Benign galactosemia also you have oil drop cataract. So the answer for this question is going to be classical galactosemia. Classical galactosemia, where you will have this sort of problem, and the diarrhea is not related with the galactosemia. Diarrhea is not the feature of galactosemia. So maybe that this baby is also having little lactose intolerance, but because they have given the oil drop cataract, that's a very strong hint that baby is having allergy to galactose or lactose containing food, and milk is having lot of lactose. So this is oil drop cataract which is giving you the answer here, and it is going to be the classical galactosemia. Classical galactosemia. So classical galactosemia, what enzyme is deficient? Now that becomes the next question. So this is galactose and this is galactose 1-phosphate. This is going to be glucose 1-phosphate and this is going to be glucose 6-phosphate, which is used for glycolysis, which is used for glycogenesis, etc., etc. This is the galactose metabolism. It's not very complicated. It's a very straightforward, simple pathway. Galactose, galactose 1-phosphate, glucose 1-phosphate, glucose 6-phosphate, and utilization. This is going to be galactokinase enzyme, and this is going to be galactose 1-phosphate, uridyl transferase enzyme. Galactokinase and galactose 1-phosphate, uridyl transferase enzyme. You have a block here. You have a block here. In classical galactosemia, and when you say benign galactosemia, you have a block here at the galactokinase enzyme level. This is benign galactosemia, right? It's going to be benign galactosemia. So whether it is benign galactosemia or it is classical galactosemia, you do not have proper utilization of galactose in that baby. So what happens? This galactose is excessive. More amount of galactose is circulating in the plasma, and that galactose will enter the lens where it is converted to galactitol. You must know all these things. Galactitol. The galactose is reduced to galactitol by aldose reductase enzyme. Aldose reductase enzyme. So galactose is converted to galactitol by aldose reductase enzyme. And this galactitol is going to absorb a lot of water and will burst the cell, resulting in cataract formation, oil drop cataract. So whether it is benign or it is classical galactosemia, baby will have cataract. And not in benign, but in classical galactosemia, you have galactose 1-phosphate accumulation, right? You must know that galactose 1-phosphate, which is accumulated in classical galactosemia, is a strong inhibitor of glycogen phosphorylase enzyme. The enzyme glycogen phosphorylase, which is important to release the glucose to the blood after glycogenolysis in case of hypoglycemia, is inhibited by galactose 1-phosphate. So what will happen? The baby will get hypoglycemia. Frank hypoglycemia means the symptomatic hypoglycemia in case of classical galactosemia, right? But not in benign galactosemia, because benign galactosemia you do not have galactose 1-phosphate. Benign galactosemia you just have frank galactose, you do not have galactose 1-phosphate. So no inhibition of glycogenolysis, no hypoglycemia. But in classical galactosemia, baby will have frank hypoglycemia. This is also important for you. You must know this. Right? Any doubt in this? You can ask me. This is a live session going on. So guys, you can ask any doubt, any question or any further recall if you have. Right. Now coming to next question number 5. Mr. X, a chronic alcoholic in the middle age, was rushed to the clinic by wife. Complaint of generalized weakness and lethargy was there. Wife added that husband is recently started telling vague stories about the past and sometimes even refuses to identify her. This is something interesting. On examination, intern on duty is eliciting global confusion in that patient. To and fro movement of the eyeball, failure of hand and eye coordination, difficulty in walking in the straight line. So it's a classical presentation of Wernicke-Korsakoff psychosis, which is due to B1 deficiency, right? So what deficiency and what management strategy must be adopted? So injection of vitamin B1 must be given. It's a severe deficiency of vitamin B1 in chronic alcoholic, which presents like this. It's a very typical presentation of, it's a typical presentation. Each and every word they have presented. Typical presentation of Wernicke's, W-E-R Wernicke's encephalopathy. There is another problem, similar problem, which was which was described by another scientist to Korsakoff, which is known as Korsakoff psychosis. In fact, it is interesting to know that Wernicke and Korsakoff were independently, parallelly working on the same manifestation of B1 deficiency. Wernicke scientists named it as Wernicke's encephalopathy. Korsakoff named it at the same time as a Korsakoff psychosis. To avoid any confusion, they clubbed the name and they started calling that presentation of B1 deficiency, severe B1 deficiency, as Wernicke's Korsakoff psychosis. They started calling it as Wernicke's Korsakoff psychosis. This is due to severe B1 deficiency seen in chronic alcoholic who do not take proper nutrition because they get calories from alcohol itself. So in this, the presentation will be, you remember Goa. Goa is a classical triad of manifestation in Wernicke's Korsakoff psychosis. G means global confusion. O means ophthalmoplegia. A means ataxia. All these features are given in the question. Nystagmus, not able to walk in a straight line, ataxia, global confusion. Confabulation, what is the confabulation? Wife is telling now, forgetfulness is there, and confabulation is false stories, filling those memories with the false stories and which patient believes to be true. That's called confabulation. So that is a very characteristic feature of Wernicke's Korsakoff psychosis. So this is a typical presentation of Wernicke's Korsakoff psychosis in the given case, and in this the treatment is B1 supplementation, either the injection or the oral supplementation. Alright. Next question was talking about the gum bleeding and decreased absorption of iron. The answer is going to be vitamin C deficiency, because vitamin C deficiency results in a lack of collagen formation and blood vessel fragility. So that is the reason for gum bleeding. And decreased iron absorption is something interesting. Vitamin C helps in iron absorption. How? This is the lumen of GIT. When we consume iron in the ferric form, this need to get converted to ferrous form, and this ferrous need to get absorbed into the GIT mucosa, from where it will go to the blood vessels, right? So this is going to be the divalent metal transporter, divalent metal transporter 1, which is going to take this divalent inside the GIT mucosa. In this reduction, you need to have the role of vitamin C, because vitamin C helps in this reduction of ferric to ferrous, right? So vitamin C is helping in iron absorption by reducing the iron from ferric form to the ferrous form. All right, so iron absorption is going to be deficient in vitamin C deficiency. All right, very good. Coming to next question number 7. Which of the following is the rate limiting enzyme of heme synthesis? What is the answer? Anybody? Heme synthesis. What is the rate limiting enzyme? It is, in heme synthesis, the very first enzyme of heme synthesis is the mitochondrial enzyme ALA synthase 1. And this is the rate limiting enzyme of heme synthesis found in liver, right? So this is going to be the rate limiting enzyme in the liver. And ALA synthase 2 is there in the bone marrow, and that doesn't act as a rate limiting enzyme, mind it. So ALA synthase 1 is going to be rate limiting enzyme of heme biosynthesis. Right. Coming to next question. Oxaloacetate is derived from which of the following amino acid? So you must know aspartate is the one which is going to produce you aspartate. Remember 3 things here. Aspartate, after deamination or transamination, it is converted to its respective keto acid, which is oxaloacetate. Alanine, after transamination or deamination, it's converted to its respective keto acid, that is pyruvate. Then third one, glutamate. After deamination or transamination, it is converted to alpha ketoglutarate. Nobody will tell you all these 3 lines at one place. So try to remember this. This is the core concept of the biochemistry. When you are talking about the amino acid transamination, you must know that aspartate corresponding keto acid is oxaloacetate, and vice versa. Like if oxaloacetate captures the amino group from some amino acids of somewhere else, it will be converted to aspartate. Alanine and pyruvate, glutamate and alpha ketoglutarate, they are respective amino acids, keto acids, right? So if you know this concept, you can very well apply this concept here and easily answer that aspartate is the precursor of oxaloacetate. So whenever aspartate transamination is taking place, it's going to get converted to oxaloacetate, which is going to enter the TCA cycle, right, and run the TCA cycle. All right. Now coming to the next question. Interesting question. Transport of glucose to the contraluminal side of the intestinal membrane. Be careful. This is lumen, and this is GIT mucosa, and this is blood vessels. Blood vessels. From lumen, the glucose is going to go to the GIT mucosal cell by SGLT1, right? So glucose comes here, and this glucose comes to the blood vessels by GL2, GLUT2. So it is asking contraluminal side, that is basolateral side. At times it is called basolateral side, contraluminal or basolateral side. There you find GLUT2, which is going to absorb the glucose and will dump it to the blood. So glucose is going to come to the blood via GLUT2. So the answer for this question is going to be transport of glucose to the contraluminal side of the intestinal cell is GLUT2. GLUT5 is for fructose transportation, and SGLT1 I have told you at the luminal side is going to help. Next question, number 10. Neonate on the breastfeeding develops hypoglycemia and jaundice. Benedict test is positive. What is the enzyme deficiency? See, hypoglycemia is a strong hint here. Just now in the previous question I explained you, only in classical galactosemia you find hypoglycemia. Reason being, galactose 1-phosphate is going to inhibit the glycogenolytic enzyme glycogen phosphorylase. So you will get hypoglycemia, right? And it will damage this galactose 1-phosphate will damage the hepatocyte, and hence the functioning of the hepatocyte, where it is going to conjugate the bilirubin and helping in its excretion, is getting compromised, and a lot of bilirubin is refluxing to the blood, resulting in jaundice. So the baby is having problem with the liver, and positive Benedict test due to presence of galactose in the urine, jaundice due to hepatic damage, hypoglycemia due to inhibition of glycogen phosphorylase enzyme by galactose 1-phosphate. It's all hinting towards the classical galactosemia. And I have told you in the previous question that enzyme deficiency in classical galactosemia is galactose 1-phosphate uridyl transferase enzyme. So this is how step by step you have to analyze the question and find out the answer. Don't immediately jump to the answer. So how many of you have attempted it right? You have to identify the case. Breastfeeding is a hint that it is galactose or lactose related problem. Hypoglycemia is a strong hint that it is a classical galactosemia. Jaundice means hepatic damage due to galactose 1-phosphate. Urine Benedict positive means galactose is coming in the urine. Why? Because galactose is a reducing sugar. It will give you Benedict test positive. All right. Very good. Now coming to the next question, 11. Which of the following is best known to facilitate entry of cholera toxin to the intestinal mucosa? You need to remember it is going to be GM2 gangliocide, which is important for cholera toxicity, right? Next question. Patient complaining of diarrhea, dermatitis, loss of hepatitis and defective wound filling. Diarrhea, dermatitis. I was discussing you in the previous question where the full recall was not there. In that only defective wound healing was mentioned. But it's such a catch. Defective wound healing means you have to talk about zinc. And diarrhea, dermatitis, loss of appetite, they are all associated feature of zinc deficiency. That is why it is very rampant nowadays when the baby is coming with loose motion diarrhea. The attending pediatrician always supplement zinc, right? Very good. Now coming to next question, number 13. 65-year-old male with coronary artery disease coming to the physician for follow-up. He is 6 feet tall, very tall, like Amitabh Bachchan, and weighing 84 kilo. BMI is 25 kilo per meter square, slight obese also. BP is sort of okay, 130-80 milligram. Where is the hint? Till now there is no hint, but tall height is some hint, right? Now further if we see, glucose is within range and homocysteine level is high. Okay, it's a homocysteine urea. Homocysteine is high. Normally it is 5 to 15 mole per liter. In this person it is going to be 19.3 mole per liter. So this homocysteine is high. Serum lipid is reference range, and what enzyme deficiency do you suspect? So in homocysteine urea you have cystathione beta synthase enzyme deficiency. Cystathione beta synthase enzyme deficiency. Right? This is the methionine metabolism enzyme which is going to utilize the homocysteine and make you cysteine. So cystathione beta synthase enzyme deficiency will result in classical homocysteine urea. So this is a condition of homocysteine urea only, where homocysteine level is high, and the answer is cystathione beta synthase enzyme deficiency. Right? This is alkaptonuria. AGPRTase is Leschnian syndrome. Cystathione gamma namak koi enzyme nahi hai. There is no enzyme named as cystathione gamma synthase, right? So answer for this question is going to be Option C. Any suggestion, any doubt? Please ask. Coming to next question. It's a very old question. Cardiolipin. Cardiolipin is DPG, diphosphatidylglycerol. It's a phospholipid. It's a phospholipid which is DPG is diphosphatidylglycerol. Diphosphatidylglycerol, and this is seen in inner mitochondrial membrane. So cardiolipin is found at inner mitochondrial membrane. Coming to next question. Child who has accompanied his father to a fish farming area in his hometown accidentally ingests a white odorless compound. Fish farming. The person was under some medication and post meal he developed toxicity to the drug. Which of the following toxin is most likely cause for this condition? So only hint is the fish poison. Fish poison. Rotenone. Rotenone is the fish poison, and this is colorless also. So this is going to be the answer here, colorless, odorless compound. This is going to block the complex 1 of electron transport chain I was discussing in the previous question. Alright, so this is a fish farming area, means some fish poison must be there to capture fishes. Right, so rotenone is the answer here. So these are the questions which we have accumulated. Now if you have any other suggestion, kindly say something about some other question if you remember. Please ask. So beautiful paper, I must say. The questions were all very important, and the same questions organized in a different format, I can say. Old wine in the new bottle sort of. They have given a very good clinical cases, you know, along with each question. So you must know that what is the deficiency symptoms of zinc, how the selenium deficiency manifests, how the galactosemia is differentiated in classical and benign galactosemia based on hypoglycemia as a feature, right? So those things were there. So if there is no question, then thank you very much, and wish you all the best.